This is Clinical Group 6, and we're doing an evidence-based practice, and our group is me, Brooke Popejoy, Savannah Brown, Jamie Martin, Chloe Vitale, Amanda Folio, Christopher Pugh, Brooke Kavisinski, and Hallie Dart. Post-operative surgical patients, how does non-pharmacological prophylactic interventions compare to pharmacological interventions to prevent DVTs in post-operative patients? Alright, so the clinical relevance of this is that DVTs can be life-threatening, VTEs can be fatal. Preventing DVTs is important, and prevention can save patients from a life-threatening emergency and also can help prevent longer hospital stays.
Our first article is Graduated Compression Stockings as an Adjunct to Low-Dose Molecular Weight Heparin and Venous Thromboembolism Prevention and Surgery. So this trial was a randomized controlled study. So the methods are a randomized adult elective surgical patients with moderate to high risk of VTEs, and these received current standard combined with low molecular weight heparin with the mechanical compression stockings, or just low molecular weight heparin alone. So 2,236 patients were in this study, and they were looked at for over 90 days. So the findings of this study are that low molecular weight heparin as well as the compression stockings worked the best in preventing bleeding and mortality rates.
Our second article is called Rate of Venous Thromboembolism After Complex Lower Limb Fracture Surgery Without Pharmacological Prophylaxis. This was a controlled study, and between 2005 and 2009, there were 11 men and 6 women, the mean age of 45, and they underwent temporary fixation for a total of 3 femoral and 20 tibial fractures. These patients were screened for VTE using contrast. And then between 2009 and 2013, 18 men and 4 women with the mean age of 45 years again went through the same procedure for a total of 8 femoral and 20 tibial fractures. These patients were routinely screened for DVT using ultrasonography in high-risk patients. Only mechanical prophylaxis was used. The findings of this article: of the 17 patients in the early group, 5 developed VTEs at a mean age of 13.6 days after injury. Of the 22 patients in the later period, 10 developed VTEs at a mean of 13 days after injury. Go ahead.
The article 3 was DVT prophylactic after TKA. They had patients that were at risk for a VTE using a DVT score chart in this randomized research study. This was randomized by computers, and the nurses, they ended up having randomized studies that were put into envelopes and picked at random. Treatment was a randomized study using anticoagulant injections and aspirin tablets for patients at high risk for VTEs. 8 patients in this study developed symptomatic symptoms of a VTE. That is also compared to the 11 that were at the at-risk group in this randomized study.
So our fourth article is called Sequential Compression Devices in Post-Op Urological Patients, and it's an observation trial and survey study on the influence of patient and hospital factors on compliance. It's an observational study. 100 patients that were undergoing inpatient urological surgery were enrolled, and all had SCD sleeves placed pre-operatively, and then post-operatively, the observations determined that SCD compliance and reasons for non-compliance. So at discharge, patient survey gave knowledge and attitudes regarding SCDs and bother with SCDs. So the findings were that compliance was 78.7%, and non-compliance reasons were that the SCD machines were not being initially available on the ward because they weren't being restarted promptly after the patient was returned to the bed after surgery.
Practice guidelines are the prevention of VTE in orthopedic patients and antithrombotic and prevention of thrombosis. So the name of the organization is American College of Chest Physicians, and this is in 2001, and they recommend for total hip and knee replacements, 10 to 14 days at least of antithrombotic prophylaxis. So this would be low molecular weight heparin, low dose unfractionated heparin, adjusted dose vitamin K antagonist, aspirin, or an intermediate pneumatic compression device. So in patients undergoing major orthopedic surgery, the panel suggests dual prophylaxis. So this would be at least 2 and a pneumatic compression device. So in patients undergoing those major surgeries, they have an increased risk of bleeding. The expert panel suggests that using an IPCD or no prophylaxis rather than pharmacological treatment.
So what do the different strength levels mean? There's strong recommendation with moderate quality evidence, grade 1B. Benefits clearly outweigh risks and burdens or vice versa. Strong recommendation, low or very low quality evidence, grade 1C. Benefits clearly outweigh risks and burdens or vice versa. Then there's weak recommendation, low or very low quality evidence, grade 2C. Uncertainty in the estimates of benefits, risks, and burden. Benefits, risk, and burden may be closely balanced.
Current practice in our clinical facility says that nurses stated they use sequential devices, heparin or Lovenox, and then you need to make sure you get a doctor's order before starting them, except for the SCDs, you can just do that. And anticoagulation therapy will be managed in accordance and with established literature guidelines for the patient, and the ordering physician will be the primary responsible one.
Recommendations for this are using SCDs and low molecular weight heparin. There's further evidence to support SCDs. We also need to look at patient cooperation, and there should be no complication with anticoagulants unless the patient's family or the patient is against using them. Some of the barriers to this research study were patient compliance and patient understanding.
So we've talked about our clinical relevance, and we've also talked about things that are in the guidelines and what St. Joe's West does. So we're at St. Joe's West, and what we've seen a lot of is most patients that come back from surgery, because we're on a surgical floor, are on low molecular weight heparin, primarily Lovenox is what we see.
Then they also have SCDs ordered, and they may be put on at the start, like right when they come back from surgery, but then patients take them off. So I think they just use it to help out, but they're not necessarily like the only thing they're relying on to prevent DVTs.
So even though it is evidence-based practice to use the SCDs, the sequential compression devices, that can be hindered by patient compliance.
Yes, just read it from the slide.
What does strength level mean?
What does strength level mean? Okay, I don't know. Strength level.
I don't know, surgical patients and thrombotics.
Okay, yeah, I don't think I'm gonna write that.
No, just give me some bullet points. Help. So, prevention of VTE in orthopedic surgery patients, type thrombotic therapy.
That's Hallie right there. Most angriest creatures in all the world.
Antithrombotic.
I poke her once, I'm dead.
Colon.
I'm gonna touch it.
Antithrombotic therapy.
I don't know what to say. There's so much.
That's going
Ball.
We weren't kidding.
So what am I saying for this? Just the name?
No. Go ahead and talk.
Hello, my name is Jamie Martin, and we're doing a presentation over DVT.
You ready?